Hi colleagues, Nadeem will be with us in a second. I've just spoken to him, so I know he's joining us properly. We'll just put the agenda up so that you can all see what's coming. In fairness, we're still a minute early. You're all so keen and eager. Hi, Will.
Hello.
Hiya.
My first two contributors are already here. That's always a good sign. Yeah, Paul, did you?
Can you just confirm the Ukrainian and the Easter holiday scheme? Because I thought I was going to talk about the recruitment fair.
You are. You're not talking about that. We've got speakers further on the agenda for that.
Oh, brilliant. Thank you.
You won't need to make it up then.
Yeah.
No. It got muddled in its sequence, but we have a speaker later on. Paul is covering that. Don't worry. So you're going to just remind people about Clarity TeamNet and then also the recruitment fair.
Yeah.
Hi, Nadeem.
Oh, hiya. You all right?
Yes, I was just saying, our first two contributors are here, so that's always good. And I saw that Greg joined us, so we're starting to fill up bit by bit.
No, I'd give him a few minutes and we'll start.
Oh, yeah.
Nadeem, Karen, I have to go. I've got a bit busy outside at the front, so I'll be about 5-10 minutes. Is that okay?
Of course. We look forward to having you back when you get there.
Yeah, sorry about that. I didn't expect everybody to decide to have the vaccine today, but yeah, so I'll be back.
Easter holidays, that's it.
Get out there jabbing.
Yep. Bye.
Bye. Hi, Sabir.
Hi,
John.
Sabir.
Good afternoon.
Afternoon.
Good afternoon, Mr. Rook.
I can remember 2 years ago, we had to work in Easter holiday. The pandemic was so worse. Trust me, it was so frightening. We learned a lot.
Yeah, we forget. We move on too quickly, don't we, Sabir? And we forget,
I know.
Quite how ingrained it all.
Definitely. Yeah. But those deaths and those unnecessary life loss will remind us all the time. Because so many people died, we could have probably, if the vaccine would be more faster, probably we could have prevented those kind of death by looking at the retrospectively now.
Like double, wasn't it, Sabir?
Yeah, it's sad.
Double the normal death rate, I think, for that year.
And huge toll emotionally on all the GP staff, because I think it remains with you, doesn't it? Hi, Jenny. We're just waiting a couple more minutes and then we'll get started. We've got about 20 at the moment, Nadine.
Have you got slides as well?
No, he's just on the hoof.
It's just verbal today, Nadeem. Sorry.
No worries.
I think people are packing their baggages and leaving the.
Yeah, they've gone to stand in an airport queue.
I was going to
probably.
say, if
That's
they
why
are, they're standing at the airport, not making any progress with security. Right.
So hi everyone, NHC webinar for April. Welcome. Packed agenda, as you can see. If you can kindly mute if you're not speaking, just due to background, and regards to presentation, take questions, either raise your hand or put a question in the chat bar. Is Arpana here, Karen? See her. So if you can maybe look at the, keep an eye on the chat bar, Karen.
So I'm happy to keep an eye on the chat function. Yeah.
Okay. So first we've got Paul Brown, who's our Director of Ops at the Fed. Hi, Paul. We're going to give an update on some of the support and give us an update on a future recruitment fair. So I'll hand over to you, Paul.
Brilliant, thank you, Nadeem. Yeah, so the two updates I wanted to share. First off is around Clarity TeamNet. So we've now, on behalf of all practices, purchased a further 2 years of Clarity TeamNet. So that was rolled out to practices, I think, about a year ago. All of the practices in Newham have access to it and will have been issued login details. At the moment, we're predominantly using it, or practices can use it for HR purposes and for sort of CQC compliance type activities. It's really helpful for PCN staff, so being able to share records amongst between practices. And then in terms of the CQC and policies, it's a really good source of good standard practice policies that you will need for, you know, safe and effective running of practices. So that's available for everyone, for all of the practices, and if anyone requires any assistance in accessing it, I'd ask them to get in touch with NHC. Durga, who has helped set this up for all the practices, is available to provide some support for that. I see there's a hand up from Bapinder. Bapinder, do you have a question, please?
Yeah, just wanted to say thank you for buying it again for us. Must have did use it in the first couple of years, but we're getting into it now, and we had some training for our practices this week. It's quite impressive what it can do, and it saved a lot of headache in terms of our old systems. Although we had fully digital systems, this is just a bit more slick and a bit easier to share. The reason why we got into it is that we were using Bluestream and other training sources like that, and we found out that TeamNet do a full training package, and it turned out not only it's a lot easier to use and a lot better, it's got all of the training packages you need in one place. It's worked out half the price of Bluestream, and I was wondering if NHC might be interested in supporting other practices to do that. That's the first question. And the second question is about joining TeamNet up with but maybe you want to answer the first one and I'll.
Well, so Bhupinder, what training has it got? Is it the mandatory training, like kind of health and fire and safety and all the modules we have to do?
Yeah. So all the mandatory training, and what used to take me an hour to do somewhere else, 20 minutes, which is a big time saving, and it's designed being focused on anything else. So just want to share that good news.
So Paul, do we have the training as part of it as well, or is that another package on top?
It's a bolt-on, so it is there and available. For the NHC and PCN staff, we're currently using the Bluestream. So we looked at this actually in the past week, because our Bluestream contract runs on for, I think, for another 12 months. We are mindful to just see out to the end of that for the NHC and PCN staff that we employ. But I think there's definitely a lot of sense in just having a single provider for the training right across Newham and just have it all in one place, because we've struggled with staff with, you know, they've got it on different portals. And so I think, Bhupinder, you're absolutely right. We should put it all in one place. So with, you know, planning the year ahead, I think we should try and sort of phase it over the course of the next 12 months. As contracts come to an end, rather than trying to do a big piece of work now. But if practices want to move over to it sooner, then I will definitely support them do that.
Yeah. Thank you very much for that. We bought that
Yeah.
package. We're very happy. The second question is now, we've not really populated TeamNet much, but in Tower Hamlets they've been using TeamNet quite a lot, and they've actually had a GP called Dr. Kenny, who's been for the last 3 years. His main job has been doing just populating it with guidelines and resources and publications or local contacts and services. Now, we have not invested in Newham that much time and effort. Buying TeamNet doesn't mean you've got resources. Mostly it's about updating it and keeping it, relevant. So he's been doing that, and he's been asking for us to connect it up to Newham for some time, because most of the stuff they've got in Tower Hamlets refers to Bart's Hospital. So actually it would help us quite a lot to share all that information, and I'd love to see it across Waltham Forest as well, if possible. So if there's a possibility of joining that up and maybe doing some education around that, I'd love to support that and be part of that if possible. Thank you.
Sounds like a good idea. Thank you, Bhupinder. If you could maybe take that forward in regards to TeamNet, would that be all right?
Yeah, no, I'd be happy to do so. Yeah.
So Sabir and then William. Sabir?
I just wanted to say there's a 4 platform people are using. One is the Blue Stream, one is the TeamNet, one is the e-learning for the health, and the last one is Practice Index. They all have their strength and weakness. First, I said I have got no conflict of interest with Practice Index, but I need to tell this is the platform where the people can download the guidelines and the protocol policies, and they can adopt themselves. That is the only had this functionality. But if the TeamNet other can provide those kind of infrastructural support to the practices, I have got no objections. But we must remember the people look for those kind of policy, and CQC very heavy-handed on to see, do you have really policy, whether you follow it or not, do you have it? That's it. So that's what they want. So I will be very careful to switch over to in one platform, because they are all different and different modalities.
Thank you, Sabir. But it might be maybe a moderate kind of term plan to get a consensus in Newham, and maybe we can work together for that. Will?
Yeah, it was just really to kind of echo what Bhupinder was just saying, just really around the joining up of GP TeamNet. So where I previously was, we managed to launch it across all 8 CCGs footprints, all practices, and actually the CCG, as well as the acute, as well as community, as well as the mental health, all had logins to GP TeamNet. So they actually had landing pages in each of the GP TeamNet. So it stopped a massive amount of email traffic and attachments. But actually what it did is almost had a bit of a library for a go-to space if people needed to kind of have, you know, updates on referral forms or anything like that. So certainly if that's an appetite, certainly we can pull some of that information from Southwest of how it looked. Certainly that was a conversation that I tried to have when I first started in NEL. That is a live conversation with Osman and the digital team anyway of what that looks like. But it was that kind of shared kind of platform and an intranet for for primary care, as well as that support function back to practice.
Yeah, just want to say, Chair, if you don't mind, is that my frustration is we've got 30 odd clinical leads in the 3 in TNW. Each one of us got information to share and update. Doing it through a website is difficult. At the moment, the most useful information is done through WhatsApp. It's embarrassing to say that the latest guidelines Imrana just sent out was through WhatsApp. Now, if there was a joined up approach to TeamNet, she could update her bit of it. I could update my bit of it, and then we'd all know where to go. I'm sorry.
Yeah, the only thing with the WhatsApp, you have to be on the WhatsApp to get the information, don't you? So you can't be put on it.
Yes, exactly.
Yeah, no, I agree, Bhupinder. I think maybe that's how we move forward. You're the IT lead, I believe, still, aren't you? So yes, maybe if you could.
Getting TeamNet is just a strategic thing. I mean, I think it's much more about giving everybody logins to add data themselves. So if the
Yep.
hospital want to update their protocol, they can do it themselves.
Can you take that forward, Paul Bhupinder?
NHC
Yep.
can have that function because you link everybody up for us. I mean, that's how I see NHC. You're
Yep.
my joy. You're the glue for me.
That's
I go
fine.
to you. You're my one-stop shop.
That makes sense.
Thank you for that. Is that all right,
liaise
Paul?
with
Could we take that
Kenny.
forward?
Yeah, I'll liaise with Kenny, and then I'll catch up with yourself as well, Bhupinder, to
Thank you
take
very
that
much.
forward. Brilliant.
Thank you.
Thank you. Right, so that's the Clarity TeamNet. And then the other update that I wanted to share was around a recruitment event, a recruitment fair taking place on the 13th of May. So we've booked the Stratford Town Hall, and we're working closely with the training hub in pulling this together. And the idea really is to promote all the different primary care vacancies, jobs and roles and opportunities that are happening in Newham. So we've invited physician associate leads, social prescribers, personalisation, nursing leads, to be able to meet with people to explain what the roles are, what the opportunities are, how you could take part in training, get on the relevant courses, but we'll also be asking all the practices for any job vacancies that are live so that we can promote those. And we are aiming for a sort of a lively day to get as many people, new people, into the workforce in Newham. So that event is taking place on the 13th of May. We're just beginning to advertise that more widely. The Training Hub have put this on the, I believe, on their website. We've got it on our own website. A couple of asks for everyone is if there's any GPs that would be available that day, that would be really helpful to have your involvement. And like I said, we'll be contacting all the practices in the next couple of weeks to see what vacancies you've got. So if you can share that information, that would be really helpful.
Thank you, Paul.
Yeah,
that sounds like a good event. Anything we can do to kind of promote Newham, and you're right, we need the right people there to promote Newham, and anything to help with kind of recruitment would be great. So let's hope it's a positive outcome. Manuel?
Yeah, I had my hand up. Sorry, thanks for the time, but hand up for regarding TeamNet. Is if I was to take the scenario of the Central One PCN, we got 3 different TeamNets logins. One for the NHC, who provide us HR, and we got one for the PCN, Central One PCN, and the individual practices have 3. So if a staff is working across, I think the 3 different TeamNets are kind of not linked up. So I think it would be good enhancements to have if a staff is working for a PCN but employed by NHC and deployed to a practice, that staff access or their files or their rota or absence record, if they could be viewed across the 3 different organizations, that would be good.
Is that right, Paul? Okay. Anything in the chat by Karen?
Only me saying let's try and work with Manuel and Bhupinder to bring that consolidation together. That feels very helpful.
Okay, thanks for that, Paul. Sorry, Wax, you got your hand up.
It's all right, Nadim, I'll put it in the chat.
That's fine. No worries. If there's nothing else, then we'll move on. I will. William, who's our Director of Primary Care for Newham, along with Tara Hamlets from Forest, just going to give us an update on PCN development support and the PLT.
Yeah, no, that's great, Nadim. Thanks very much. Yeah, so I think I'm glad I saw Tammy jump on, because I know last time Tammy nailed me last time to say, where's the PLT session? Where's the funding for it? So hopefully Karen can now set up and say, yes, the Federation have the funding now to cover the out of hours arrangements for the PLT sessions going forward. So hopefully that's good news. And that's part of the equalisation, because it's not just all about the funding, it's also about the opportunities and the very good of a training exercise. So what we need to try and do is work with the training hubs on what that offer is from point of view of whether it be monthly, quarterly, face-to-face, online. I think we should be flexible with that and be able to utilize all of our new skills that we've heard honed for the last 2 years of online and face-to-face. Obviously face-to-face is very good, because I think you get a lot more out of it than just sitting in front of a a 24-inch monitor or whatever size monitor you're sitting in front of. So that was one good piece of news. Just on from point of view of, we were fortunate or unfortunate in kind of that we had some underspend in T&W, and certainly for primary care we put forward some bids for that funding. So rather than it being taken off elsewhere or being moved back to NHS England or to other schemes, we put some bids in. So we were fortunate to land those, and have been fortunate to work with your Fed on housing some of those funding and also those new roles. So some of the areas I want to just talk through. So there was an IMS coordination role that was funded by the region, and it was a 0.5 role, and I think it was quite hard to recruit into that role, so we weren't able to give you that kind of IMS support function. But what we have done is now top that up for this year. So ultimately there will be 3 immunization coordinator roles that'll be basically housed at the Federation, but ultimately coming out to work with practices to really understand immunizations in the round. So it's not just flu, it's not just childhood, it's not just COVID, it's all of those, be able to kind of use them as a, those kind of understanding why we're not hitting those targets, and obviously, or if there's some functions that people need training or unlocking from point of view of the data recording and all those kind of things. So that's one of the area from point of view of that we've been able to resource for this financial year. And then just on the next kind of area, we again, as part of the funding, we put in for some PCN kind of OD support, which I think is the lion's share of the funding, and it's really kind of just to add to more kind of managerial and kind of that focus piece, where we've obviously just wrapping around support around the clinical directors of kind of where are we going on this journey. Obviously, we've got our development kind of process in place with MIAD, but actually this is just an extra layer on to go, right, what do we need, how do we need it, what does it look like, just so we've got that kind of tangible kind of extra support. Because I know I hear loud and clear regularly that actually you're very, very busy, very, very busy clinicians. I know you have your CD time, but actually having that kind of managerial support and next to you, which should hopefully allow us to kind of be a bit more kind of sleight of hand and being able to demonstrate by for me the added value of these roles of the delivery plans and kind of where we need to try and invest and get that variation and that quality kind of back to where we all hopefully want it. So those are the kind of, I suppose that's the kind of investment that we've been able to kind of achieve, which again is a thank you to the Federation to working with us on hosting that and housing that. But that for me is kind of really the kind of overall good news, I guess, is one of the areas. What I will say is I just wanted to take this opportunity. Obviously, I know there's been lots of conversations and noise just around kind of PCN reconfigurations and kind of where people want to go. I think what I wanted to say is, and I know I haven't spoken to all of you, but I wanted to say actually that there's been, we need to kind of have that construct and conversation in an open, transparent manner. And I think there's a formal process that we all need to undertake, because ultimately this decision will sit with NEL PCCC from point of view of that whole construct change. I suppose I kind of obviously being new to the area, and I know that I've been here a year now, if you can believe that, is actually just around how the construct of the PCNs were made up. It just on looking at it, and it kind of, I see it myself as a newbie on that, is it really it doesn't look sustainable. It doesn't really look that kind of linked up or coordinated, and it would be good, I think, at some stage, certainly this year, that we could kind of, how we come round the table to have that kind of conversation of what does good look like from point of view of a PCN footprint, and actually how do we look at that geographical simulation from point of view of the wards and the boroughs, and that delivery of service in those natural kind of boundaries that we all do. So very happy to have a conversation with anybody about that. But I wanted to just say, look, actually the decisions are going to be open and transparent, and actually there's a formal process that we will follow through. And again, like I said, is kind of when will be a good time to have that conversation from point of view of that whole PCN construct of, how many, what kind of structures it look like. So I suppose I can throw that out open to the floor, and I suppose any questions would be gratefully received.
Thanks, Phil. So yeah, PLT, I mean, we've been kind of asking for it for many, many years. So I suppose about time, but thank you for the PLT and
yeah,
the
thanks,
support.
Nadeem. That's like a thank you, but not really a thank you. Thanks.
And OD support for the networks really appreciated. So hopefully we can help our networks to develop. And you know, the feedback about kind of reconfiguration of networks, that's quite helpful as well, because there's been a lot of noise in the system. Tammy, and then Bhupinder.
Thanks, Nadine. Thank you, William. I'm just going to say thank you. That's great. I just had a question about the immunisation coordinator role. So just an understanding, because obviously a lot of the work is about out in the community and trying to do that community outreach and having those appropriate community comms. So would that also be included in that role, in those three roles, to support us in doing some of that work? Because it doesn't make sense not to if we're really trying to kind of have that joined up piece of work. So just clarifying.
No, really happy. And Tammy, if you're able to be part of that conversation about where they want it, how we want to deploy them, that's really, really welcome. Because I think for me there isn't a kind of thou shalt do, this is what they have to do. For me is around just knowing how the whole kind of immunization, not only the vaccine hesitancy and its round. I think there's a conversation we need to have there. I think there's also being able to go out and like you're saying, be more sleight of hand of where we're going to deliver these types of services. I think there's a conversation certainly around the roving model of how do we input into some of that. So very happy for you to be part of those kind of conversations. Like I said, we had a very, very finite window to put these bids in, so they weren't fully formed and fully homed. So there is certainly wriggle room and time to do that focus.
Oh yes, well, thanks William for all the PLT. Without any conditions, I say thank you. And I also welcome your honesty and openness about reconfiguration of PCNs. And I'm aware that we've been the cause of a lot of upset recently. But you know, just to be sure that we're not doing this to upset anybody. It's about our own mental health, and it is mental health. The number of meetings we have to attend to every single month, in addition to our own internal practice meetings, are just unsustainable. And the requirements on PCNs are increasing. And I think really PCNs need to start thinking about merging practices and becoming more closely aligned rather than just sitting in silos. And that's my own personal opinion, and I wouldn't dare push that on anybody else. But I just think it's about survival, and that's maybe where we're going. And so because we're now almost 40,000 patients with our current sites, we've made this request before. And it's just become very difficult. So anybody wants to talk to you about what our problems are, it's not a criticism of anything that's happened in the past. I don't regret not being in a single PCN to start off with. I don't think we were big enough or even ready mentally or psychologically. So everything that happened in the past was correct. This is not, I'm upset about that. This is about the future.
So for me, totally thank you very much for that. I think for me, it's very much about the sustainability, but also around what that footprint looks like, and then the deliverability to services. So thank you very much for that.
Thank you.
Thanks, and I'm sure we can take this conversation, Bhupinder and William, outside this meeting. Just going back to vaccine hesitancy, Will, quite important, because I think there's a lot both in children and COVID and flu, and I don't think we've quite got to the bottom of what the reason is and the understanding, and that's really good that we've got these extra input for immunizations, because I think there's some work to be done there to understand and start working towards improving our kind of figures and targets, or towards the targets.
Yeah, Nadeem, one thing I will say is I know I've also done the similar thing in Tower Hamlets and Waltham Forest around the immunisation coordinators. I do think it would be really helpful if the federations could have a conversation around the vaccine hesitancy, because I think actually if there were a helpline or a team that could be put together, I think doing it across TNW would be really beneficial.
Yeah, that's fine. Thank you, Will. Anything in the chat bar from Alpana or Karen?
No, Greg has just referenced that obviously there's a keenness for an open discussion that you've identified, Will, around PCN development, but I think generally comments being pleased around the opportunity of support for PLT and PCN development. Is it worth, Will, I wondered, do you just want to outline in terms of the PLT process? So the funding that NHC's had is really about providing cover to practices, but the content and the way in which practices want to deliver their PLT is going to sit with the practices and in conjunction with training hubs. So
So obviously the construct of the funding obviously is with the federation to cover the telephones ultimately, and that kind of urgent and necessary under your core contract. It's not a like for like replacement service of a general practice. I think there's more, like I said, Karen, obviously from point of view of the training hubs obviously are the deliverers of service from point of view of the training. I think those PLT sessions, and somebody I'm sure will correct me, but actually for me is if we were launching new services or having that kind of wider conversation, we would be bringing some of those to the PLT sessions. But actually, again, is obviously I know the Suli's on the call, but ultimately is working with the training hubs on what does that look like. And obviously, you'll be aware the training hubs are also going through a bit of a reshaping as well, and reforming, and or certainly rehosting, because ultimately it'll sit with the Waltham Forest Federation. But actually, what is that whole training package that sits for the next 12 months? And actually, for me, is how do we plan that, and also how do we hear from practices and PCNs of what the need is, so we're proactive and are able to get that kind of done, not only on a borough but a TNW and an L level.
Yep, I agree, Will. In terms of it needs to be appropriate for all of our workforce as well going forward. Wax and then Greg.
Yeah, just I tried to stay quiet, but I can't stay quiet. Sorry, it's about the vaccination. So in my spare time, I do lead in NEL on vaccination and immunization, and I'm absolutely all ears to understand and hear. We want to hear, Jenny want to hear what works for practices. We know it's been very, very difficult during COVID, but actually when we looked at the data that's been presented, actually we're doing really, really well. So actually Newham is on an upward trajectory with other boroughs are on a downward. But that's not to say that the work's not done. We're shy of overall by about a few percent under 80%, which is like where we are in across the country. Look, open to any ideas, email me. But the kind of things that we do here, and I'll give you an example, is around door knocking, actually finding out whether those individuals lived there when they haven't responded to a call and a text, etc. That is labour intensive, and absolutely what we do going forward needs to recognise that kind of labour intensiveness and that extra work that goes in to get your vaccinations to 95%, etc., etc., etc. The other thing that we've noticed is that when we looked at the graphs and the data, first doses are really, really good for MMR and DTP and whatnot and stuff. But when you get to 5 years old, things start to drop off. And that's consistent in North East London and London across the borough, but not so much across the rest of England. So something's happening. We need to work differently with our partners, with our schools, with our early years institutions about promoting this vaccination, and actually think of different ways of modes of delivery. Just done a vaccination for a child who's autistic, and the parent said, can we come and get the second dose done here of his MMR booster? Because it's quite difficult to manage in the so there's things that we need to think about across PCNs to help each other out as well. There are people who we can't just get to and convenience and actually need a bit more extra support. So plenty to think about. Do share your ideas and good models, whether it's door knocking, whether it's actually taking your vaccine there and giving it, whether you're sharing it amongst your PCN, and we can think about packaging this up in a way of supporting practices. I try and stick to promises and stuff like that. I've always tried to maintain that, and if it's incentive that we need on top of coordinators, well then so be it. Make that recommendation as well, because actually absolutely recognise the extra work that goes in to get us to the 95% and the 100% that we're being asked to get. Okay.
Thanks. Greg.
Yeah, excuse me, like Wax, I wasn't going to say anything, but just want to quickly kind of explain my comment. Be careful what you wish for. We completely need a conversation around PCN configuration as groups of practices working collaboratively. What I really think we need to be wary of is if or how that conversation becomes a conversation about reconfiguring general practice and the model of general practice. And what I would urge people to do is read the Health Foundation report, which would explain why I'm so paranoid about this. You know, PCNs may be around in 2-3 years' time. They may not. General practice will be.
Okay,
Yeah, really,
good point,
really
Greg.
helpful comment. Yeah, really helpful comment.
Anything else in the chat bar, Karen? No, there's been some comments from Lizzie and
Yeah,
I think hesitancy.
Yeah.
We need to, and I did mention whether we need to do some deeper delving or research or to partner research institutions, because I think hesitancy is a problem locally in all of the vaccines, and we still don't understand it really. But I think that's a good point by Lizzie. Anything else, Karen, in the chat bar?
No, you've got it. Just that reference from Lizzie that people are, sort of struggling to engage in their real lives. I think.
And they want an alternative, but they're not sure whether you have to.
Oh, sorry, I thought that might be coming through. So, but yeah, we can take that forward.
Thanks, Will. Thank you, Will. And hopefully we'll give you an update on PLT and the PCN support going forward.
Yeah, we can get the training hub, because obviously that for me is really their kind of ticket, and they obviously just need to link in. So very much, and again, we can bring back certainly around the IMS post and kind of what that looks like would be really helpful.
Thank you. Thanks for all of that, and thanks for the PLT. No conditions. So next is Tammy, our LMC chair, and Greg to give us an LMC update. Hi, Tammy.
I think we've jumped on the agenda.
Have we jumped?
Go back to the borough partnership item, Maggie. So Rima and John, that we're going to give us a short.
Apologies for that. So yeah, Rima, who's our chair of the borough partnership, and John Rook, director of delivery. I'll hand over to you to give us an update on the Firebase Partnership, which is our new structure going forward, partly replacing the CCG.
I can get the slide up if you haven't got it to hand, Maggie.
Okay, thanks Nadeem and Karen for inviting us today to share, sort of give an update on the Firebase Partnership. So as we move obviously to the formal process in July, we have had some external facilitated sessions for partnerships members to attend and work through some of the well, not issues, but some of the sort of important aspects of how we move forward. And one of them has been around sort of the governance and work streams, which we recently had. So on your screen is kind of like a proposed sort of governance structure that we're looking at. Please ignore the fact that it says Waltham Forest Borough-Based Partnership. It's obviously Newham, but the structure is sort of similar across the 7 boroughs, and we're trying to equalise that across. So having a look at this, it's all about what functions are going to be delegated at place, what functions will be delegated from NEL to the partnership for delivery. Obviously, we really recognise the importance of developing our primary care networks, and I'm really glad that Will has sort of talked through that, and that there is a clear commitment in supporting our PCNs to support the delivery of our plans. So the next thing is also about leadership. So there has been discussions about what the clinical leadership as well as non-clinical leadership of the Firebase Partnership will look like. So at the moment, there'll be a primary care development lead and a assistant lead, which will be on the clinical side. And then there's been discussions about an overall lead looking after basically the whole system. And that will be working closely with the director of delivery, which John is in post at the moment for. So there have been sort of discussions about who would fit that role, whether it would be a member of the partnership already or someone external, and that's what we're sort of discussing through our development sessions. But well, the reason I've wanted to mention it today is because I think it's really important to get views of our primary care colleagues about that. Obviously, it's in the very early stages, but I think it's really sort of important that we sort of get that right. My personal opinion is we're probably not in that place where we can have one particular provider leading across the partnership. Currently, it's still in this immature form. That would be my personal opinion, but there will be some others that will have different views, and that's what we're sort of talking through at the moment. In terms of other things, I think that those are the main sort of discussions that we're having, but I just wanted to make everyone clear that myself, Wax and Karen are here. If there are any views that you have, please kind of share it with us, because these are really sort of early important discussions that we're having, and this is what's going to shape the future of Newham. So I'm going to bring John in if there's anything else that John would like to add.
Thanks, Rima. So we're in the middle of sort of building the aeroplane while flying it, and that's across sort of northeast London as well as within the borough. So lots of discussion. What is positive about how this is being approached is we're being asked our opinions. So we're not having stuff laid down for us by northeast London or much at all from nationally. It's very much what's going to work for you. So when we're discussing what type of leadership model do we want, how do we make sure that all partners are represented and feel active and connected to this partnership, as well as how do we get clinical leadership better. And part of that is we're making requests to invest more in clinical and professional leadership across the borough. So we're putting that forward to make that request as we think about levelling that up. And thank you to all of you who participated in our Clinical and Professional Senate to start those conversations and help us with that. That's been really, really powerful. One of the things we're very, very keen to do is while we set this governance that is very much the background to what we do. It's always the way that you have to go through all of these discussions when you reset all of these structures, but very, very keen to keep focused on population, our communities and what we could do better for them. So particularly as we think about some of the issues related to the cost of living crisis, we're going to hear later a bit about some of the response we're making to Ukrainian arrivals as well, is making sure that the governance very much supports us to be very good at supporting our communities and people, and that's forefront of our mind. And through our Clinical and Professional Senate, make sure we are serving our staff really well. And so we've started that process of how do we engage better, how do we do better, how do we improve things, how do we give the right support and infrastructure, training, data, whatever it might be to make us more effective at what we do. So while we go through a lot of boring discussions about governance, terms of reference and delegation and so on, with the eyes still very much on the prize of the people of Newham.
Okay, any questions, Karen? Can't see any hands raised.
Not currently. Oh, Martin.
Martin?
Yeah, thank you, Karen, and thank you, John. For me, I think one of the recurring topics of discussion was around recruitment and how do we ensure that we are able to recruit, in my opinion, from the pool of talent we have within Newham, and how do we encourage people to put themselves forward, because I think the last clinical lead recruitment round there were some gaps, and I don't know whether anyone has any thoughts or answers, but in a previous discussion that was had, there was a few ideas floated around, like going beyond Newham or looking at a wider pool of staff. I do think we have the talent of salary GPs, local GPs and other clinicians within Newham. So I guess there's a question of, John, is there sort of a sort of plan when it comes to promoting these roles? And lastly, my second question, which links into that, is there a particular timeline for recruitment or in terms of when these positions may be advertised so we can all go out and encourage people to put themselves forward? Thank you.
Thanks, Martin. The timelines aren't yet set, to be honest with you. There was talk about trying to do this in May or June. I think that seems ambitious, so I think those timelines may slip. We will let you know. I think you're absolutely right. We haven't been able to fill some of our crucial roles. So WACS and Despair have been filling in to do learning disability and autism for some time now. But we know we're keen to have a role around that. So we've already started talking to different staff groups about it, knowing it's coming. And we definitely want to promote that in a broader way possible when we think about some of these roles, so that we are planning a campaign to get people to understand what the roles are, but also I think what we didn't do very well last time was say what support we'll give the roles, and what training, development, leadership support and management support we're going to put in place for them. So I want to be much clearer about that so people know they're applying with the opportunity to grow and develop, but also have the management support with them. Because I think the last time we did it in the middle of a pandemic, we didn't do that, and we've listened very carefully to the fact we didn't get that right. So one of the things we're discussing at next Clinical Senate is about training, and development, leadership development, and really want to explore some of the things that clinical leads want to be equipped with, so we can build that training program up and that support program up to give everyone the best opportunity to lead effectively.
Yeah, so to John and Rima, so I suppose a lot of the people on the call right now are may not be clinical leads or even thinking about applying for clinical lead positions. So I suppose this new structure, I suppose what they probably might be more interested in, and I might just be speaking out of turn, is how does this make primary care stronger? How does it improve services and make life slightly more bearable for the GP or someone working in general practice? Any comments about that? We have structures which change every cycle, don't we, in NHS? I mean, I've been through 2 or 3 cycles already in my career.
So I think I just wanted to start off, Nadeem, just to go back on Martin's point, and then I'll come to your point. I think it's important that we are socialising these roles a lot more. And I think last time in the round of recruitment, as John said, it was during a pandemic, and I think we just didn't do enough communicating out. And that's why we've started this process really early on with the clinical senate as well, and trying to appeal to our younger leadership that I just think haven't had the opportunity to come forward to really understand that there is, as John said, support and development in these roles. Historically, it's just been about, you do the clinical role, you do your sessions, you fix problems when they're needed, and that's about it. There hasn't been that scope for development. But we, as in the restructure, we're trying to attract even more staff from NEL to actually come within Newham as well to support those roles. We have thought about a new clinical role for workforce, which will be 2 sessions I think we're looking at. And I think that will make a difference, because that role will be primarily dedicated to supporting new roles, recruitment, etc., working with the training hub. So I think that's a new thing that's going to happen. I think that's clearly going to I'm hoping that will make a difference to attract more recruits in Newham. I think that partly answers your question, Nadeem. But I think it's about, more about I think some of us also have a responsibility of those that have been in roles to talk to younger leaders or those leaders that haven't thought about these positions before, and really sort of say, these are the good things about it. There's a number of us that have been in Newham for a while and in these roles, and we're in it because we want to do it. And I think we need to share that. And
so my question was more about, how do we get primary care resource? So we're funded with about, 10% of the NHS fund. How a successful change would be if we could get a more appropriate or reasonable proportion of NHS income. So in this new structure, that was my question really, about how do you strengthen primary care and how do you strengthen the services we have in the community and parts. But that's my question. But it's fine. We'll probably leave it at that. Is that okay?
That's fine.
Wax and then Manuel.
Yeah, I think the only thing that I would add, and John and Rima, Martin, Nadeem, you've talked about the challenges, is that it's good to be in a role, but how can I put it? So the conditions that support that role need to be the same for everybody. So the same as they are for managers, they have to be for clinicians, etc., and stuff like that. So I know things like maternity and sick pay and all of that kind of stuff, and annual leave, and that, because we do these roles and we told we do this many sessions a week and we just do them. But what happens if you go off, or what happens if you want to have a baby? Do you know what I mean? So there's plenty more that we could do to make these roles more attractive, because Martin's right, there is a talent pool and we are working on that. So Agenda for Change conversation with LMC colleagues and others across North East London, we are having those conversations. But these roles, to make them more attractive, you need to be consistent. There's 800 people who work for North East London, and the conditions for all of them needs to be the same. So we're a bit behind the times, but absolutely we're trying to get there. These, in terms of when these kind of things will happen, I know there's some NEL primary care roles that are going to go out to advert on April the 24th or 25th. Jenny will correct me. They're sort of like the NEL roles. Then you're going to have your system clinical lead and primary clinical lead, which we have to have, and then there will be then the recruitment after that for other clinical lead roles. John's right. It took us nearly a whole quarter last year. It's probably going to take us probably longer than that this time round. So we'll keep everybody posted, and yeah, let's see if we can get as many of our clinical leaders and bright stars into these roles, so we can carry on doing the best patients.
Thank you much, Manuel.
Yeah, just to add to what Wax said about conditions, it's also important for the practices to have the right learning environment as well, so that the staff could be supported, because that is crucial to retention, and people who are ambitious for leadership, they need to have the right environment to thrive in. The practices also needs to be supported to create that learning environment.
Good point, Manuel. And Dr. Werner?
Yeah, hi everyone, very interesting discussion. I was just wondering whether we have had any feedback from the clinical leads in place so far. I mean, I used to be the TARMET's clinical lead for long-term conditions till 2019, which I greatly enjoyed. That was preceded by a I think 6 months training course on leadership, and it's greatly helped me both in my academic work, as well as in joining the Mayors of London roadmap to eliminate hepatitis C, as well as other roles. And you know, I've had very senior people backing me up and supporting me throughout, including Sam Merrington, to get onto the London board. So I think it's I'm just saying this because I've had good support and good training all the way along. And it would be very interesting to hear experiences from those who have been in place so far.
Thank you for that. Is there anything in the chat bar, Karen?
Not specifically. There's a bit of conversation about how we support the roles and the management support combination, I think is being identified.
All right. Well, thank you, Bimo and John, for coming down then. And hopefully you'll come back again to give us an update on the PLT partnership as it evolves further, or the plans evolve. So Tamiao, NMC Chair, and Greg, I'll hand over to you just to talk to us about some of the joint working and what NMC have been doing locally. Hi, Tammy.
Thanks, Adam. So we thought we would just have a little session and give you some feedback about what we've been doing, trying to develop that unified voice forum and space for us to have some of these discussions. And we've got sort of some joint areas of working that we're looking at. We've got a draft. So we thought it was important to kind of share as we have our conversations about what good looks like in Newham, how we can work together to achieve that, and also who we need to have around the table for those discussions, and what data, what dashboards, we see a lot of data, how we're going to use that to sort of support some of these conversations that we've already had so far today. So breaking it down, it looked like for me, it sort of fit into sort of 3 key areas. Now, this is just the start. I think there's so much, but we needed to sort of break it down into sort of bite-sized and manageable portions. And I think as we go along and we gain some experience about the structures that we need to have in place, the conversations that we need to have in place, then obviously we will endeavour to add to this list. And I suppose that's what the purpose of these meetings are, for us to look at all of these ongoing issues, and then to try and have some prioritisation that we can sort of work towards, so that we can learn from that and sometimes transpose some of the ideas to other areas. And if it's really, frankly, not working, that we've got a forum to dismantle it if needed. So ideally, we're sort of looking at, sort of the funding and investment, and we've talked about this. It's really important that Newham gets its equal share, but sometimes it's about who advocates for that, who needs the support, what conversations need to be had. And so we really tried with these meetings to look at, sort of how we could make that happen, what we needed to take to our commissioners, what we need to take to that sort of place-based partnership. And we thought, it's really important to look at how we maximise the investment into general practice. Not only just locally, but what do we need to do when with national schemes? Where do we need to sort of put our head above the parapet? Me taking things off to the London Diabetes Clinical Network, for example. This is the issues that are happening in Newham. I need some support in training. We need some additional money in the system so that we can run some pilots and test sort of ideas out. That's the kind of thing that we want to be able to sit down, and we don't want to be doing that in silo. And as we said, we've got many clinical leads, and sometimes it's about how we can leverage together to sometimes bring some additional funding in, but we need a space to have those conversations. So that's what we're sort of looking at. Also about, and next sort of column, the representation and the communications. Now, it's really hard to know how to communicate. There's so many of us. There's a lot of people that are leaving, that churn in the system, making sure that we've really got up-to-date communication. So whether we look at that TeamNet as a way of doing that is obviously an option, but we need to have an agreed framework and processes to support the communication and those decision making. What we don't want are people to be missing out. So we need to know how we can. Who do I need to go to because I have an issue and I really want some additional support or data to maximise the influence at a certain meeting? So we need a forum to come together where we can do that, but also to build on the engagement, the communications with the GP practices, so that it's a two-way street. People feel that they've got an environment where they can have their voice heard, and by coming together, it's that community of practice where our voice is strengthened, but it is based on that communication to our members and received from our members. So that's what we've really been, sort of focusing on, and how we develop those structures. And then the inevitable and ongoing issue about sort of workforce and our workload issues, so that we do have a space where as primary care and GPs we can come together and we can discuss what our recruitment needs are, the issues around our R's roles, making sure that we're not undercutting each other and sort of poaching and staff, that kind of thing, but also how we can have a collective, sort of when we look at what the needs are for Newham, where are our gaps, that we can then have a list that we can almost give to our training hub and say, look, this is what we need to work on. And we've already had those discussions, and there's some action. It can be a smart thing. We've got time frames involved, and we've got the right people around the table that can make that happen. I'm going to jump to that and say that that's part of what worked with PLT. It was about that unified effort, but also making sure that we had the data that we needed to give to Will so that Will could make it happen. Thank you again, Will. But also, feeding into and having that idea that no one is working alone, and this is where the well-being really comes in, that we have an idea about what our GP capacity is, what our pressures are, where the demands are, the inappropriate shift of work to primary care. How can we make sure that we've got a forum to say, look, this is something that's happening frequently. It's not about sending lots of different service alerts and us not having that space to actually look at the volume and say, this is a problem within our system. How can we make sure that if that is something that we feel we could cope with in primary care, that we are resourced appropriately to do that? Or is it that actually we need to sit back and say, do you know what, absolutely not. This is our consensus view as GPs. It's an absolute hard line here. So we're trying to make sure that we link all of these things in together, and that we really can map what our needs are, and that we have the the skill mix and the people who can, and the roles that can make this happen for us. Because what I will say is, if you have all these wonderful ideas, but you don't have somebody who can make and help you make those decisions and get those into action, then it does become rather frustrating. And it's one of the reasons why I think people leave. So in all of our discussions, it's about how we retain and recruit staff, but we do really want to make sure that this is a great place to work. And in order to do that, we need to be honest and have a discussion forum where we can sort of iron out all of our difficulties within our kind of unified voice space. It doesn't mean that we have to all agree, but it is really important that we have a forum to have that discussion, and then we can have that influence. We can have that. Sorry, I'm getting a bit of feedback. We can have that. Oh, thank you. We can have that feedback, and we can use that for our clinical leads to take to various meetings, and we can support the leaders within our system. But that, I think, when you've got that good support structure, I think that's how you attract new leaders, because they know that they're going to have that support network there. So so the only thing that I was going to say when we talked about the PLT, and just to add on, I think it is really important for us to map what our priorities are within Newham, and that our training programme really helps us deliver that. And whether it be that we need some training on how we do good templates, how we make sure that all our staff are using the templates appropriately, those kind of really practical on the ground issues. That's something that we can sort of certainly pick up. It's great to have trainers within the system who want us to be very good with our medicine. Absolutely, that's important for our appraisals, but sometimes it's also about the practicalities of it, because that's really what people find difficult. How do I do this? And if I don't know, where do I go to do it? And so I think that's really important that we have a repertoire of the how to do things, and that we can constantly be reviewing. And I think that shows that as a system that we're really keen to encourage QI growth, and that in itself will attract new investment and will put us on a nice shiny map as we continue to want to be, and show the really good work that we do in Newham for our patients. And ultimately, as we've all said, it's about making sure that we can deliver excellent care for our patients. So I think I've covered what I wanted to say. Greg, was there anything that you wanted to add to that before I take any questions or comments?
No, thanks, Tammy. Spot on.
Thank you.
Karen, anything you want to add? Because I know you've been involved in some of the work with Karen and Greg.
No, I guess just to underscore that this is something that we've tried to help facilitate this conversation and get as broad engagement, and I'm sure Tammy, Greg, and certainly ourselves that we may have to revise this. This is very much a sort of discussion, but it feels like a really good starting place.
Yeah, and I suppose, Tammy, also it's important that we have a strong voice going forward in primary care, especially in these kind of new structures, and there's worries about dilution of our voice and representation.
Absolutely, and I think that just harks back to Greg's previous point, which is GPs will be here, but we need to. So we have to, as the smallest unit, primary care is the smallest unit, we need to make sure that our voice is heard, because we do the lion's share of the day-to-day work that impacts our patients.
Dr. Werner?
Sorry, you're on mute.
Yeah, so sorry. Yeah, very interesting. Thank you. Such an important topic, really, isn't it? I have. It just reminds me of a small pilot study I did with a organizational researcher from Middlesex University a few years back, interviewing Tower Hamlets GPs and just looking at their struggle with work. And a lot of this has got to do with how the NHS is structured and the mismatch between the structure as well as how we operate as human beings emotionally. So it's more of a question really to you guys in Newham, because we've been meaning to get more funding in, but failed on two rounds. So I think they're setting up a bigger team at Middlesex University, but I would be very keen to do something like this with our Newham colleagues. She's new to the NHS. She's well established in the field. She's a senior lecturer. Very new to the NHS, and would keep an external eye on how we operate. So it's just something I wanted to mention here. If there's anyone, I think maybe there's two things. I think we'll get research funding at some point. It's just if I could have anyone who would support us on a senior level from you guys, then please just drop me a line, because I think we're still seeking people from the from commissioning or senior GP level to support us.
Greg.
It's just kind of looking at Claire's question in particular. I think one of the kind of key things for me is we need to get the Newham voice and representation right, because there will be representation at the North East London level. There's, you know, they're setting up what's called a primary care collaborative. We need to get the borough voice and the borough representation right if we're going to have any chance of influencing what goes on at the North East London level.
Thank you for that. Thank you, Tammy and Greg. Thanks for that. We're just running a little bit late, so I'll have to move on. Thank you. Next agenda item is Laura Croft, who's our Director of Public Health locally, going to give us some information and an update on recent arrivals in Newham. So I think that's part of that is Ukrainian refugees and existing Ukrainian people of Ukrainian kind of descent locally. Hi, Laura.
Hi, thank you. I think, Maggie, do you want me to share my slides?
I've got them here.
Oh, brilliant. So you have to. Oh, yes, you're on the screen now. That's brilliant. Thank you. Thank you. I'm sorry, I'm one of the assistant directors of public health in the team. And I'm just, I think, how long have I got? About 5 minutes? I know we're overrunning a little bit.
Yeah, we're about 10 minutes. Is that okay?
10 minutes, that's absolutely fine. Yep. So basically I'm here today to really talk about what we've been doing from a public health Newham Council perspective in terms of coordinating our response to not being aware that there are some new arrivals already from Ukraine coming into Newham, and we're expecting more over the coming months. And it's also in the second part of it. So some of it's telling you what we've been doing, but the second part is really thinking about how we update yourselves in terms of things like resources that are coming our way or developments that we're making, because there's a certain essence when there's an emergency response of information overload and things coming multiple times in different directions. So I can pick up that at the end. So this is just the first few slides are just very much setting the scene. So Newham has the highest Ukrainian population in London. That's the 2021 census data. And if you don't mind going to the next slide, Maggie, how we were thinking about initially was around that we'll be thinking about the three groups. So Ukrainian residents already in Newham, and this side is initially thinking about it from a sort of visa migration support. So they may be wanting to extend current visas if they're on temporary worker schemes. Then the two groups that have come through from the visa schemes that have been opened up since the war in Ukraine began, the family visa scheme, where people do not get remuneration. So that's just if you've got family members in Ukraine, you could open up. And we also don't know the data in terms of the numbers of people who've been opening up visa applications this way. So we know in general, actually I was on a webinar this morning, I think about 65,000 people have applied for visas in the UK. And I think they're processed about half of that. The numbers arriving are much lower. We do know more data about the Homes for Ukraine scheme. So that's the number of people who've opened up their homes. So they're sponsoring people to come here and stay for a minimum of a 6-month period. That's about 130 homes in Newham have opened themselves up, and that's a lot of work for the housing team in terms of making sure that there's a suitable, safe accommodation for families to come to. And then we also, this third group, and we're also thinking about that we know people will arrive through different routes, and that might not be from one of those two more formal routes. You happy to move to the next slide? So our ambition is very much that what we want to do is we want all of our response to be about meeting the needs of any asylum seeker or refugee arriving in Newham. So we're very conscious that we've still got Afghan families and hotels in Newham, that we will be having refugees from different countries across the world arriving in Newham. So we see this as an opportunity to really use our systems well for any refugee. And actually it's quite interesting that some of our responses are really building on some of our responses around COVID too, which I'll come on to later. And then the next slide just gives a little bit of our objectives, and I'm not going to talk through this. It's more just to say that we see health in a very holistic way, that some of the most important things in terms of provision are around supporting financial support, making sure that people can get registered into schools. So how we're thinking about our response from a Newham public health perspective is very much about that, all the different things that you'll need support within those first few weeks of arrival and months. I shouldn't say just weeks. So the next slide talks a little bit about how we've then developed that into a structure. So we've got a strategic project oversight that's being led by someone in my team alongside the safeguarding lead in the council. And then we have these various clusters. And my role is I'm the lead around the physical and mental health cluster. And that I've got various people I'm working with, including Lucy Langford, and I'll go on to this too, so that's building a lot on her work that she's already been leading in this area. So that's how we're organising our response, and we're meeting weekly to feedback on the various cluster leads. And we've been meeting for about a month now. And then the next slide will be telling you a little bit more about some of the resources we've been developing. So maybe it was about 4 weeks ago now, actually, we held an initial event, a drop-in event at Stratford Library, and we developed this leaflet, which is now in Ukrainian and Russian and is on our website, which was just that initial signposting of information and support. And that was a really useful event because it allowed us to think about how do we reach our Ukrainian residents in Newham. And we use things like Ukrainian restaurants in Newham, where donation points were, and use WhatsApp and Facebook. And we got a good number of people attending that at Stratford. And that's been informing how we're developing a bit of a suite of information resources. The one on the right is just a draft copy because we're hoping to finalise them next week, which will just tell, and we want them to be developed in a way that you can send them out through WhatsApp, or they can be, so it's quite text light but clear about where do people need to go. I've been advising one around accessing healthcare support, and that's been working in partnership with people like Lucy Langford, but I've also been working with around adult emotional health and children and young people emotional health, and linking up with talking therapies and CAMS around that. So that's just a bit of some of the information that we've been developing so far. The next slide, this week. So last week you might have got through people like Maggie, me and Lucy developed a bit of an information resource sheet which brought together various websites and about guidance around thinking about that initial health assessment for Ukrainian residents. And then lo and behold, this week a published website was developed by the UK Health Security Agency, which is great. So that sort of brings those different bits of information that we shared through the initial resource last week into one web page in terms of national guidance. And I'm also flagging up that there's been guidance about how to navigate and understand the NHS produced in Ukrainian and Russian as well, which is the infographic on the right. So to just help people understand the NHS. There's a really interesting NHSE webinar this morning that I attended, which talked a bit about, had a Ukrainian talking about the differences between healthcare structures, and they did say that primary care is something that would be quite different for Ukrainians coming to here, that they're much more used to accessing specialist service support initially, and they're not very much used to waiting times either. So that gave us some good kind of insight into some of that management of how the NHS works compared to how healthcare services would work in Ukraine. And then the next slide is, yes, so alongside that information support, but also thinking about that broader frontline people support. One of the things that was flagged up early is that people worried about the trauma that people will be arriving in Newham with. I've been working with talking therapies around a sort of 25-minute YouTube film, which is very much emphasising that some of the key areas around supporting someone who's arriving with trauma around that sense of safety and connection, thinking about the Maslow hierarchy of needs in that, but also signposting where you can get further support and advice, such as from talking therapies. And once that should be finalised next week, and we can also share that. And we've also been building on our COVID-19 response. So we've been converting our Newham COVID-19 champions into a broader, we've sort of been using that model to develop a welcome Newham champions. So this is very much for any refugee and asylum seeker, where they can get some regular updates and information. And from next week, we should also have a welcome to Newham health helpline, which is again very much building on that COVID-19 model. And I think what that would be great for is it will provide, when we are experienced with COVID, it was a lot about it. This is form filling and signposting to support. But also it gives us some intelligence and information back about what are the key concerns people are raising. Is it about how to open a bank account, or is it about I'm not sure how to register with my GP, or how to get help with a doctor? So it gives us some of that intelligence coming back about how people are experiencing accessing services in Newham. And then the next slide. So, and that was just my a big general point too, that a lot of this work isn't new. It's been work that that Lucy's been leading on around the safe surgeries, but we've also developed, we developed last year, we're working with migrant families and our Director of Services, which is a PDF document, and we can talk about at the end of this how we maybe bring all these resources into an easy portal or something for you to access if needed to. So, and then the next slide, I think, is a continuation of that, which is one that Lucy added, which I thought this was a very exciting ambition for us to be the first London Borough at all GP practices of safe surgeries. But yeah, just to really reiterate, there's already a fantastic resource for social prescribers that was supported through Doctors of the World around supporting asylum seekers and refugees. There's a lot of good practice that we already got in place in Newham. And Lucy, I've got, yeah, I'm sure you're probably, I don't think she's on this call because I know she's on leave today, but we've got our email addresses as well. She says she's very happy for anyone to talk to her more about that. And my last few slides, so alongside the Newham resources, there's Pan London resources. So Thrive London this week published some free training webinars around trauma-informed practice that they're running in May. They've also developed a short guide to helping families in Newham, and that sort of follows the 5 ways to well-being tool in terms of thinking about self-care and mental well-being. This would be quite a good resource for, particularly for families potentially hosting new arrivals. And as I say, we've got close links with our housing teams to help share some of these documents as well. And then the last slide, I think, continues on the Thrive London scheme, which is that, yeah, this builds on existing resources too that have been developed for the Afghan communities. There's a short video, and this was done last year as well, around supporting refugees and their mental health. And the charity Solace has also got a couple of free e-learning resources to support mental health practitioners and I guess anyone working in a frontline space. I was just going to add too, because I spoke with Dr. Siddiqui this morning, and she reminded me how the Good Thinking website has a very good, quite simple to use trauma workbook, which includes quite a lot of illustrations, which she finds very useful as well to be able to use and signpost people to. So this is my kind of whistle-stop tour of all the different things at the moment this week that we have. Some of the response challenges, obviously there's this unknown scale of need. We feel that we're getting small numbers coming to Newham. They are arriving. This might increase a lot in the next few months. So we know that the London City Airport's becoming a welcome hub. But we really don't know. There's no clear modelling, and we are trying to develop a bit of a data dashboard. So, for example, we know 25 children have registered in schools. We know some people are asking for ESOL support. So we've got some sense that services are being accessed, which is great, but we don't quite know the numbers, and it's likely that that full picture will never quite be known. We know that a lot of this is coming at a time when there's a lot of other system challenges in terms of capacity and resource. And we also know that we're in another reactive environment in the sense that new resources are being developed all the time. So we're very aware about that risk of information overload, you receiving the same information 3 times. So I'm keen to think with yourselves about how we help kind of reduce some of that too. And I think this is my last slide, which is some of the questions. How can we support you? So one of the ideas we could do something like, if you do have a weekly newsletter, we could just share something each week to make sure that something's in there of any new resources or any new information coming through. Feedback to us. One of my colleagues mentioned like a sort of MS form survey. Like, is that useful for you to be able to feedback to us what challenges people are telling you that they're experiencing? And that can be quite wide. It doesn't have to all be about health. So obviously, it can be if they're experiencing particular housing challenges or financial challenges. And anything else that you think might be useful at this stage. And those are our email addresses.
Thank you, Laura. Thanks for that, really helpful. Karen, if you can just ensure that information goes out to the practices. Anything in the chat bar, Prana? I mean, I assume the information has gone out to the social prescribers locally, along with members of LBN.
Yes, so we've already distributed the stuff that Lucy kindly shared back end of last week, and happy, Lucy, to include further information going forward. Okay. I think there's just a couple of quick questions. So Vishali, just asking about the volume of children. I think you referenced 25, Lucy, but sorry, Laura, but I guess just a sort of concern about the numbers of children was one of Vishali's questions. And then Subir Dr. Sen asking about whether there's access to Ukrainian speaking advocacy service for face-to-face contact.
Okay. Is that okay, Laura? If you could maybe either let us know now or give us information through Karen.
Yes, I can on the face-to-face. I'll just add, because I didn't mention that we already have a Connect Newham, a befriending service, and we've been talking to them. That's run by Age Group UK, but it's kind of like a hub and spoke model. So they work with other charities in Newham about how we can use existing residents who speak Ukrainian in the borough to be volunteers for that, so that we can provide that sort of extension of befriending support. The children and young people, we will, once we've got, as I say, if maybe Maggie might be best for me to take this up afterwards about how we share, because we wanted to get a dashboard where we can start at least sharing what data we're receiving. So again, if there's a way of usefully updating you about things that we're doing as a council to help you think about any response. But at the moment, it is an unknown.
Okay, thank you for that. Thank you for that, Laura. Laura, and we've had Lucy here quite a few times as well in terms of safe surgery, so that's great progress we're making. Thank you very much. And if you can pass that information to Karen, if you can just ensure it goes out to the practices and any new information is updated regularly. Thank you. Should we move on to, thanks for that, Laura. Should we move on to Subir? You want to give a CQC update?
Right, okay, hi, thanks everybody. What exactly I'm going to tell about a little bit about the CQC, because you must remember that CQC is not going to do any more frequency-based visit. That means every good and outstanding practice has to visit by 5 years. That's gone now. But only things are going to exist like RI and inadequate. So RI will be visited in every yearly and until they are become good, and the inadequate will be 6 monthly. And there will be no access-based visit. That means if your access is low or any kind of face-to-face, those kind of things we had it before, that's gone. Now it will be replaced by what we call risk-based. So we all have every monthly the report coming from the CQC about there is no risk at the moment to visit face-to-face. That will continue until the new risk emerges. The practice will not be visited as the time interval or access based. So be careful about whatever the risks you have. You manage your mix internally, whether it's an access risk, whether it's a patient satisfaction risk, is it a complaint risk, GMC risk. So I will advise them to manage their own risks as soon as it's evolved from any kind of feedback. So another way I wanted to deal with that, encourage the practices to become a training practices. And I just wanted to thanks NHC's the board that they have allowed me to work with Training Hub to provide the direct support to the practices who wanted to be a training practice. I just wanted to touch that bit a little bit. Already 5 practices has been enrolled to become a training practice from the August. So this is good. We wanted to make 100% of the training practices are training practice, because what evidence suggests, if you're training practice, 95% chance that you will get good or outstanding. So to be honest, it's very unlikely to put any training practice on RI or inadequate until unless exceptional circumstances. So in order to deal the CQC, it's the best thing, the positive way, move your practice to a learning environment where you can have really a multidisciplinary learning, including physician assistants, nurse practitioners, any kind of healthcare that really support the general practice infrastructure. So what I wanted to ask everybody, because the NHC is working and allow me to work with the training hub, so I'm just going to quickly going through this process. In order to training practice, there's two processes. One, a GP as a trainer, and the practice as a learning environment. GP as a trainer, these slides will be given to everyone. I just wanted to talk through this process now rather than just going to the slides. So GP as a trainer needs to go for a 5-day course. And then after that, they need to do a video consultation. If you send that video consultation to me, I will check it, and then I will do the peer review. And then what will happen, I will send you an application form. I will visit your practice. Already there is 5 practices I have been visited, and fortunately all been now converted to become a training practice, and hopefully they will be registered from 2nd of August this year. In the next lot, we'll do some more February and then finally in August, and we are aiming from 95% of practices to convert to a training practices. So what exactly will happen now? We have now internal process where there is it is done internally. It doesn't have to directly from he, though he has got has a duty and through the training hub to recognize the hardcoreship, that means the certificates and all this, but all the soft touch I can do with you, coming to the practice, meet the practice, the whole team, and discover about the ethos of the training practice. Can I have the next slide, please? Right, okay. So this quality improvement process will be happening in a different way. One, we send the applications, you will have a resource pack, then you will have a PR assessment teaching guide, then you will do a video with your physician associate or nurse or a medical student, whoever you got a video cassette recording, send it to me. I will do the peer review, and then after that, we'll send your learning environment application form. I will come and sit down with you, exactly tell, it's exactly like CQC style, because remember, all this came from the same resources called good medical practice. So these are the same thing, it's just a different variations. If you are a good practice, the 90% job is done, only 10% you need to do to show the learning environment. The next page, please. Next slide. Okay, so where I came now, if you see here in this panel, there will be 3 people. One is the preferable lead from the training hub or additional director, who is Jane William, and she will probably all be in this panel. The second person will be an experienced trainer on the specialty that is in the Newham. I will help you to come with the experienced trainers to help you how to mentor, coach, or probably get the application form and reviewing our video cassette. So at the same time, you will have an external body. You will have somebody from our ADs. We have an excellent PDs. You know already them is Uzman Bhatti. Then you have Lakvinder Lark, and then you have Shahnaz Hussain. These are the people who will also externally monitor. There will be another person externally from outside. It could be Tower Hamlet, it could be Newham, it could be Redbridge. So there is the panel. I'm not in the panel. I'm only there as an experienced trainer to give you the feedback, how exactly I know about the practice, how exactly I know the trainers. So I'm there for face-to-face support. So if anybody wants to really go with this, please give me a ring. I will come. I will have a chat with you, exactly like CQC style we'll do, and we'll get it done. Once you are training practice, I can tell you this is the best quality improvement. This is the positive energy you can bring into the practice, and that is the way you can reduce your recruitment problem. You can have a physician associate, you can have a GP register become your partner. In my practice, all my partners is my ex-trainees, and all my salary GP is my ex-trainees, all the locum work for my ex-trainees. So this is the way what I did. I can prove you that by doing learning environment, you can become your own recruitment agency. So if anybody needs any help, give me a ring. NHC is helping me. I will come with my team. And there's Kavita Gore is the training hub. She is very proactive on that. There's Sule Kangulak. She is also very helpful. So once you decided please let me know. I will do the soft work, and after that, the hard work will be done by the training hub. So give me a ring if you need any help.
Thanks, Sabir. Yes, I think we haven't got enough training practices locally. I think a lot of our GP trainers were diverted to BHR last year. And I think we were the only ones in London. So we do need to push a little bit for training practices and trainers locally. But great work you're doing with the training hub, Sabir. And any help needed, Sabir and his team can provide that support for practices. Any questions in the chat bar?
No, nothing new, Nadeem. Oh, hang on, we've got a hand up.
Manuel?
Yeah, quick question. Are you providing support for the PCN to become learning environment as well?
Yeah. So that is our next step, because remember, all this CQC business are moving to ICS PCN Federation. The focus is quality in scale, not individual practices. So the CQC will now have a new regime for ICS registration, Federation registration, at the same time PCN registration, and that will be part of the PCN can create on their learning environment. But that is the next step, because how it's going to happen, probably it will come out in next 6 months time. Definitely the PCN should be a learning hub.
Okay. Anything else in the chat bar, Karen?
No.
Okay. Anything you'd like to add? Anything you want to add, Dr. Sen, apart to what you've said?
No, I guess just to, as Dr. Sen has said, very happy to provide support to practices who are giving this some thought, and Dr. Sen's, working closely with Training Hub colleagues to make sure that we hold your hand through it, because we know sometimes the expectations just take a little bit of navigating.
Yeah, and there's a lot of pressure in the system already, so you'll need help, but it's an investment, and if you do become a practice and you get GP trainees, then that does help your the pressures and the workforce as well. Okay, if there's nothing else, I think we'll call it time. Thank you, Sabir, for that. Thank you, everyone, and see you lot soon. See you next month. Bye.
Great break over Easter.
Bye, everyone. Happy Easter.
Happy Easter, everyone.
Happy Easter.